Okay, welcome everybody. My name is Jorge Rodriguez. I'd like to welcome to all of you to this webinar on the work we have been doing regarding the vaccination, the modeling, mathematical modeling of the COVID-19 pandemic, and how we applied our models to find the best approach towards prioritization for the vaccine distribution. And I will also be telling you a little bit about the work we've been doing specifically for Abu Dhabi, and to basically share with you all the conclusions we are having and the ongoing work we have right now. I'll be sharing my screen with you, so we can have a presentation going on. I hope the screen is visible for all of you. Okay, so the title I initially suggested for the webinar was Who to Vaccinate First Against COVID-19, a model-based comparison of strategies. The order of vaccination and what to do, it's been a matter for discussion very intensively in the last few months, since many countries have realized that the vaccines were going to become available, but they were not going to be available, all of them, for everybody at the same time. So this meant immediately that we were going to have to do a prioritization, some sort of prioritization of the who's getting the vaccine first, in what order, and whether or not it would be better if we do it in one way or another. So what we did is focus our work for the last 3-4 months on that particular problem, taking advantage of some of our previous work with it for the pandemic in April. This work is a team work here, originating a work completely from within Khalifa University. It's been a collaboration from my lab, myself, my postdoc researcher Mauricio Patón, and we teamed up with Dr. Juan Acuña in the College of Medicine. So a little bit of history on why we were ready and why we had the right model for this kind of question is because of the work we have been doing in March and April 2020, just to assist and trying to find what were the best interventions, what was the impact of different interventions on the pandemic. That was a first model in which we basically distributed population in different stages of the infection. I mean, I'm not going to go into details exactly, but just to give you an idea of what we were doing. And we were assuming the infection was caused by the rate of infection depending on the number of individuals that could be infected, the number of infected people that are infectious around, and this likelihood of infection. So with all those things together, we were doing balances of the population across the stages. The different ages of the population were taken into account. That was one of the main characteristics of that model, which allowed us to evaluate interventions, for example, such as isolation of only certain types of age and not the others. For example, isolation of the elderly, or isolation of the young, and so on. So with all this information and the course we were obtaining, we were at that time assisting SAHA, the health provider in Abu Dhabi. We were meeting with them regularly in April, and we gave them advice and assistance during those times back in April. Then, as we know, time passed, the first wave disappeared, and then the vaccine started to be an option coming up in the coming weeks and months. So we saw an opportunity, because the way that model was designed, distributing the population by age already in age groups, allowed us to actually use that model to be applied to decide which groups of those groups should be getting the vaccine in different order, and try whether to see whether it's more effective to start with certain groups or others, and in what order, right? So what we did is to modify that model and created a new model in which we now have additional compartments that were not there anymore. Were not there before, right? Initially, we didn't have any vaccinated people, right? The only way to get vaccinated was by achieving by becoming infected and recovering. Right? This was the only way to get the immunity. Sorry, to become immune was by getting the infection and then recovering. Right? Now the vaccination comes into play. So when we have a healthy group of individuals here, if they become infectious, they can go through the different stages of the infection and recover or not recover. But then they can also get vaccinated. And when they get vaccinated, they become immune. So the way they interact with the other groups of the population will be different. And they are creating this so-called herd immunity that we have been hearing a lot in the latest months, which is basically the moment you are not transmitting a disease, you're like a shield to others because you're not part of that transmission chain, which protects others. So this is why we're looking at reaching these numbers of vaccinated groups. Of course, now the question comes, and okay, what is better to do? Should we vaccinate old people that are not very much interacting with others, but they could be severely affected by the disease and even die? Or is more efficient or effective actually to start by vaccinating those individuals which are every day seeing 100 people and thinking about cashier in a supermarket, taxi drivers, a lot of kinds of individuals or young people that are socializing a lot also in many countries, which is the case. What is better? Because in one, you're protecting the individual themselves, but if you also vaccinate first those that are interacting the most, you might be actually slowing down the spread of the disease at the beginning. Ultimately, obviously, everyone will get the vaccine, but here is about deciding who goes first, just to keep the minimum number of fatalities towards the end. So we're like kind of in a race between our vaccination curve and the disease fatality curve, which we are seeing in the last few months. So this model was defined with these compartments. We applied some definitions of the groups. We don't have, all the time to go into all the details, but I just wanted to give you a flavor of it. How we are modeling now the rate of infection, because this is what we are trying to really slow down with the vaccination as well as protecting against the fatality, right? So the rate of infection in this model is similar to the previous one. It is a product of factors, right? A product of the number of people that can actually get infected, okay? If everybody is immune already, then those numbers will be zero, so there will be no infection anymore. Then one factor which is very important is the average number of contacts that individuals have per day, in a day, with individuals from other groups. Now we are already looking at in-between groups because we are trying to decide which groups go first, right? So we are all doing these rates of infection in between groups. So with how many people of this age? So let's say if you're a young person, with how many people of people older than 65 you contact per day, and how many people you between 20 and 50 you contact per day. So we are making those estimations of number of contacts per day. Then another important aspect is how many of these people you're contacting, what fraction of them are actually infectious right now, and this depends on how things are going in that particular moment, right? If there's a lot of infectious individuals, because there's a lot of infections right now, then that number will be bigger. So that's another factor. Also, there are elements there, like if we are doing a lot of testing, which is one of the things the UAE is doing extensively, because of the testing, you're removing those individuals from the exposure, right? So they are not becoming a danger, because if you test yourself, you find out you're positive, you will not be socializing or you will not walking around, right? So that will decrease the infection as well. And then the last factor is this likelihood of infection. So when you have a contact with an infectious person, how likely it is that you will get infected. And that has to do, of course, with the level of protection and awareness that both sides have, right? So we model that in that way. If everybody's wearing a mask and keeping a lot of distance, the likelihood is very low. But if they are not keeping the mask, they are not keeping the distance, the likelihood will be bigger. That's how we described all that. And we described it through groups of parameters, which I'm not going to go into details, but we have all this level of PPE use, for example. We have levels of infectiousness, and we put this in for each one of the groups. We have groups here per age groups, okay, preschool, primary school children, secondary young people, working class, young working class, mature workers, senior workers, and people that are retired and older. So we define those groups to have not too many, not have too much complexity, but also have sufficient resolution, so we can have meaningful groups in the sense that they have significant differences between them, either in their behavior or either in their mortality, because that's what we're looking for, right? Looking for groups that are different, so we can prioritize them in order that is relevant for the impact on the disease. The other very important aspect is this context matrix, right? We were talking that one of the most important things, one of the factors for the infection is how many contacts you have from one group to another, right? So that needs to be estimated, and it was also based on literature that was published a few years ago regarding, they did a survey on people, so with how many people of this age you contact per day. in different countries. So we adapted those for the countries we were doing the work initially, first for Spain, and then we did that also for Abu Dhabi. So these are the parameters that go in the model, right? So once we put this in the model, what's going to be happening? What we are going to be seeing is that we start simulating different strategies. So we can say, okay, let's vaccinate everyone at the same time. So everyone with the same probability, with no priority. So as many people that comes in, we vaccinate them, right? And then we see what happens. Another option is, let's say, okay, why don't we just go first to the people with the highest mortality? Like in many countries, they are talking about doing this. The elderly first, the oldest individuals go first. Let's see what happens after we run the entire simulation of the pandemic and the fatalities towards the end, maybe after a year or after some time. How many people would die in that scenario versus the other scenario? Okay. So this is an example of the comparison of these first two strategies, right? So we see here a graph in which we see the age groups on in here, right, with the age range where they're from. This is the days that are passing in this axis, and then when the blue bar shows, it means that group is actively called for vaccination. So we are vaccinating everyone here at the same time, and this is a simulation which, as you see, is not including the children, because we know that children are not yet eligible for vaccination because the vaccines have not been approved for the use in children. Okay, so we remove them now actually from the original paper. These results, by the way, are original right now because we did just this modification days ago. This hasn't been yet published, so you're seeing it for the first time. So what we did here is to see, okay, what happens when we vaccinate the people like this? So we're vaccinating until everyone, the coverage, we're assuming that 80% of the population will be vaccinated. So we're vaccinated for this number of days with a certain rate. Okay, we are assuming is 0.75% of the population per day. UAE is vaccinating now really fast, so it's really vaccinating at a rate very similar to that. We do that, it will take about 100 days to get everyone. And if we do it this way, the black curve shows you the fatalities that could be happening. And then at the end, what matters is the final number, right? So it's an estimation here for, this is not for UAE, this is for data for Spain, okay? And we were estimating these numbers right now. What if we vaccinate now, not by everybody at the same time, but we start with the elderly? So we have the elderly. So we see here, we start with the 80 plus people, then we move to the 70, 79, 65. So if we follow this sequence, what is the final number? We have a number here that if you notice, if this was 10,000 something, it is 11,000 something. So it was actually worse in the case for Spain when they are following that sequence. That was one of the main results we got. We tried other strategies. What if we vaccinate first the groups with the most interactions, which actually happen to be pretty much following the opposite order, because the younger people are having more interactions in terms of those contacts per day with other groups. So if we follow that sequence, we would start with the young here, move to the working people here, and so on, and then the elderly are actually towards the end a little bit, according to our contact matrix. If we did that, the numbers were smaller, were from 10,000 to 9,600. And if we follow another method we develop ourselves, trying to see at every particular moment what is the best sequence, we had another alternative. It was kind of an optimization. We found another slightly different number, slightly better, but not very significant. So now this is very new because the results we got first for Spain with the children being vaccinated were showing a very strong difference in the sense that if you start with the priority, with the priority to interactions, the number of fatalities was much smaller than if you do the elderly first. Now, because children cannot be vaccinated, the difference is not that big, but it's still better, according to our results, for countries like Spain or in Europe with a lot of individuals which are old, to start actually vaccinating the most interactive and not them. The reason that we think the results are coming is that when you vaccinate, if there is a lot of old people, it takes months to vaccinate them all. That means we are not vaccinating the others, which are spreading it very much. So we think at the end, that's why the ultimate number of fatalities is better if we start with the most interactive. Well, alternatively, we also ran an optimization with what was the optimum sequence. If we run all possible combinations of groups, we obtain a better result. But this is, again, the interpretation of this is a little bit more delicate because this is model dependent. The other one is less model dependent, and this would be a very difficult to implement. This is also a plot showing how the hospitalizations, critical cases, and vaccinated are evolving through time when we vaccinate following that sequence. Yeah, we don't have a lot of time to explain everything in details, but this is the kind of work that the model is producing. The model can also evaluate. We can run hundreds of simulations. So now what we can do is, for example, look at for a given effectiveness of the vaccine, which we fixed at 87.5. We compare what if we do a comparison of no prioritization at all, everybody at the same time, versus more vaccinated by mortality. How many deaths we would avoid? Okay, and then we can plot this for different coverage of the vaccination and different rates of vaccination. So if a country is vaccinating very fast, it will be down here. If a country is vaccinating with a very low coverage, for example, only 30% of the people want the vaccine, then you could be in this area here, right? And that tells you how many fatalities you're avoiding if you do if you vaccinate by elderly first versus following no order. When it's negative, it means obviously that it's worse. We can also obtain plots. This surface, I think, is more meaningful. This one doesn't really show a very significant difference unless except in extreme cases. But here, if the vaccination rate is low, below 0.75, 0.5, which is what's expected in many places, it's very clear that by doing it by interactions is much better than doing no prioritization, for example. We could avoid in the order of 3,000 lives. This is, again, for Spain, for the population of Spain with 47 million people. Other cases, we can evaluate also what if we are vaccinating the children and what if we are not. Just the idea of perhaps having the vaccine approved, what would happen if we do that. The numbers are bigger, obviously, when we do this comparisons. If we are vaccinating first by interactions and we allow for children because they are very interactive, then the data we are getting are showing bigger numbers in terms of an advantage when we vaccinate by interactions versus when we vaccinate by mortality. So this is the kind of results that we presented these days. We applied it initially for Spain and we published it in a preprint. Because we have very good data published regularly from historic data from Spain, segregated by age. That was the main reason. The interesting thing is when we actually came out with the results, it was almost at the same time that the government was actually announcing the strategy for vaccination. And then we hit an incredible impact in the media in Spain, which we would never imagine. We did an initial interview in the paper and in El País, and then that exploded into tremendous interest. We did, I don't know, I did probably 15 TV interviews regarding these results, especially also because we were using the example of Spain, right? And they were very unexpected, results, because they were pointing at doing the elderly first, and our results were pointing, okay, hold on, that might not be the best thing to do. We might actually think about whether we should be vaccinated first, perhaps supermarket cashiers or young people that are interacting more, to actually protect indirectly the elderly, because they will be more protected from catching the disease, right? And then, yeah, that had a lot of impact, especially in Spain, but also in other papers. I think in total we have like 60 or 70 mentions in TV, radio, and press, referring to our work in Khalifa University. Then what we did lately is obviously work for Abu Dhabi as well, in the sense that we needed to help Abu Dhabi. So we teamed up with the Department of Health, with the team that is working there, with Dr. Farid Al-Hossani, which is I think the speaker that is regularly in the media talking about the situation. We work with them to provide them a recommendation for Abu Dhabi specifically. Once we started looking at the data from Abu Dhabi, we realized immediately how different the countries that are in this region are from the countries in Europe in terms of the demographics. There is much less old people in here. These are young countries, and the population is structured very different. So we had to change completely the groups definition. We defined groups for Abu Dhabi. We tailored the model completely for Abu Dhabi population structure. We changed the contact matrix, so who contacts with whom is also different. We changed the estimation of that. We also changed a little bit these behavioral parameters I mentioned before. And we ran lots of different scenarios, and we made all these surfaces of results. At the end, I mean, I'm not showing all of those results because they're still a working document. But the main conclusion was that here, because of the low number of old people, it doesn't really matter the order. So it's no issue. I mean, we recommended actually to vaccinate the elderly as soon as they can, because also, of course, there are also ethical reasons and other aspects to decide on a vaccination strategy. A vaccination strategy is not decided only by a model like this one. is decided also by many other factors. Okay, but even if you want to use the other factors, in this case, due to the nature of the population, the number of old people is very low, so they will not be delaying the vaccination of super spreaders, right? So in this case, we didn't see major differences. So it doesn't really matter the order according to our model. What's important is that a lot of people get vaccinated, and I think the government is actually doing this very wisely. Is trying to get a lot of people vaccinated, and we are UAE is leader in the world right now in vaccination rates. And I think, I think this is going to put us in a very good position. And our model is actually showing that this will be the case as well. Not only the obvious thought, but it's also our model is also supporting that. This is very different than the results we got for other countries in Europe because they have percentages of old population, which is very, very big. Okay, so to conclude, what we did with this work, with this model, is in places where there is a large proportion of elder population, it appears that you can do better in terms of number of fatalities if you vaccinate starting with the most interactive, which is somehow opposite or not in agreement with what some countries are initially doing. Not all countries. Indonesia, for example, I think is one country that has decided to go the other way, the way we are actually suggesting as well in this work. So it's not like a completely, out of the blue idea. Also, many years ago, some people found the same results for a flu vaccination scenario in which the flu vaccine was, there was scarcity of it in the US. And so it's not like a completely out of the blue story, but it's a little bit outside the general thinking of public health. And there's we found a little bit of resistance to that idea. We're not saying it's the right way or the wrong way, but it was a little bit of resistance to just saying, okay, how can you do this? You first have to go for the most vulnerable. Well, we think the problem is a little bit more complicated than this. So at least all points of view should be considered, including models and including mathematical models. Yeah, so we are saying that the individuals with high interactivity should be done. And then we developed this tool. This tool was also applied to the UAE, and we keep on working on that. And that was basically what I wanted to tell you today. We also want to thank Khalifa University. We received generous funding from the university during this pandemic. It was a very quick response from the university that allowed us to put together this team and obtain these results, which have had an unexpected big impact internationally. And also we hope it also had an impact here in assisting the government and Abu Dhabi to fight against the pandemic. So I want to thank you for your attention. I think we will have the opportunity now for some questions. So you're welcome to type the questions in the chat window, and I will be able to answer for them, to answer to them the best I can. So thank you very much, and I hope for your questions.